evening, everybody. Dr. Gautam and Dr. Banerjee, yes, and my dear colleagues. I'm sure, definitely, we are not familiar with this structure. But we are waiting here since morning for this, and I believe this is going to be center of attraction for next couple of minutes. It is testosterone. Diabetes and hypogonadism. Decades back, I can remember, the study was conducted by me under the guidance of Professor Ghosh and it included more than 200 people. HbA1c level was less than 9. None of them was obese, and they were living without any major palpable complication. And even in that population, we found that around 10% of that population is living with hypothyroidism. So let me remind us what is hypogonadism. As you know, just as a reminder, hypogonadism is symptoms with or without signs. Symptoms may be specific, like lack of sexual interest, lack of firmness in the body, non-specific features like depressive mood, irritability. Symptoms with or without signs and biological evidence of low testosterone, which is consistent, which is non-equivocal. So, keeping in mind this definition, let me cite a case which is not much unique. We are coming across this type of case every week in our practice. A 57-year-old person with a father of 2 children. He is a non-smoker. However, he had quit this few months back where he was suffering from a rheumatic infection and he got admitted in a local nursing home. For hypertension, he is taking multiple drugs. For diabetes, he is on oral and tablet drugs. Yes, definitely he is taking statin for dyslipidemia. Mood is on the lower side. His wife complains that he is often in the irritable mood. After talking to him for a few minutes, I just felt something like this. He told me that, yes sir, I am not having any interest in sexual part and the sleepiness in the morning is not as before. He was in very depressive mode, he was completely washed out. After examination, what I got, blood pressure is within acceptable limit. What you can see here, 89 kg, BMI is on the upper side. Definitely, the body weight is normal. I didn't find the gynecomastia, but certainly there was gynecomastia. And on general examination, the testicular volume is around 20 cc. He produced this whole report. This was done when you were admitted in the hospital. HbA1c you can see 8.1, hemoglobin is on the higher side, electrolyte RFP almost normal except few high value of the transaminase. And he also produced this report of serum total testosterone, and you find here it on the very lower side 138.3 nanogram per dl. When I inquired, he told me that it was done immediately following discharge from the hospital. And as you know that whenever we are planning for testosterone assessment, it should never be done in a critically ill patient or a patient who is in the recovering state. So I didn't take this serum testosterone value with lot of gravity. Also, on further inquiry told me that the sample was taken after lunch. As you know that serum total testosterone, it exhibits a definite and a very important intraday as well as inter-day variation. And the total testosterone in the serum, it gets its peak around 8 to 9 a.m. in the morning. On the other hand, the sampling was done after lunch. So I advised him for retesting, and we can share here one text from an article published in 2007. Up to 30% of older men with a low serum testosterone concentration have a normal value on repeat testing. And overnight fasting can increase serum testosterone by 9 to 16% and can reduce significant diurnal variability. On retesting, he came back to me after 1 month, and we got the total testosterone values of 236 nanogram per dl and 245 nanogram per dl. The sampling was done twice with an interval of 1 month in between. And we can see here also, definitely testosterone is on the lower side, and the acceptable lower normal range we consider around 350 nanogram per dl. Now, before I am going further, I want to explain why I am talking much about total testosterone. What is total testosterone? Total testosterone is nothing but a summation of SHBG bound testosterone, which is sex hormone binding globulin bound testosterone, which is where testosterone is very tightly bound with SHBG, plus albumin bound testosterone. Here, testosterone is usually bound with albumin plus free testosterone. As you know, the free testosterone is the main agent which is working on the receptors. But if required, the testosterone can come back from the albumin bound component, which is around 50 to 60% of total testosterone, and can join the army. So this portion is the free testosterone plus albumin bound testosterone portion. They are forming the bioavailable testosterone. Now coming to the case. So definitely, whenever we are assessing hypogonadism, the testosterone value, it should be done by a reliable assay method, and definitely we have to assess albumin as well as SHBG, sex hormone binding globulin. Now here are a few conditions where SHBG can be decreased in the case of obesity, diabetes mellitus, steroid, hypogonadism, acromegaly, cirrhosis. All these conditions can lead to lower SHBG, and also it is possible in the case of nephrotic syndrome. On the other hand, there are the conditions where we can find SHBG on the higher side, like aging, anti-inflammatory drug like phenobarbital, estrogen, untreated HIV infection, uncontrolled hypothyroidism, severe energy deficit in the background of calorie deficit or severe exercise. So, coming to free testosterone. Now we know that free testosterone can be measured by so many assays, but there is no well-validated and well-accepted normal reference range of serum free testosterone. Further, there is wide variation in quality among various methods used to measure serum free testosterone concentration. However, the equilibrium dialysis is accepted as gold standard across the globe to measure free testosterone, but unfortunately, this is not widely available. So, what we can do? We can calculate free testosterone by empiric formula, and this formula is also widely accepted. For this formula, to use this formula, we need testosterone value, SHBG value, and albumin level. And fortunately, the value which we are getting by using this formula is matching with the level which we can get by using equilibrium dialysis method. So, definitely a free testosterone result is most useful in few conditions, like the intermediate pretest probability of hypogonadism. Mind you, intermediate pretest probability, the situation which may be associated with low serum SHBG and definitely moderately low to low normal serum total testosterone level. Definitely, if the person is having total testosterone level more than 350 nanogram per day, and if he is not having any condition which can give rise to some change in SHBG, we don't need either to calculate or to measure fetal testosterone result. What next? Definitely, the person has been diagnosed to have hypogonadism. What next? Now we have to distinguish whether he is having primary or secondary hypothyroidism, and the FSH and LH sampling, the assessment of FSH and LH from a pooled sample can help us in that direction. We know that in case of primary hypogonadism, the testosterone is low, and on the other hand, FSH and LH on the higher side. In case of secondary hypogonadism, definitely LH, FSH, and testosterone are on the lower side. And here you can find the list of primary as well as secondary hypogonadism. Definitely, diabetes can develop in the background of any of these conditions, or any of these conditions can lead to diabetes. And if LH, FSH, testosterone parameter tells you about the possibility of either primary or secondary, we have to assess in that direction. But in the case of diabetes, hypogonadism here is mostly mixed hypogonadism. What is mixed hypogonadism? Testosterone definitely on the lower side, but LH and FSH, they are within normal range. And most of the hypogonadism in the background of diabetes is showing that type of character, that is the mixed hypogonadism. So how to manage it? Definitely in any complication in the background of diabetes, lifestyle management is the cornerstone of therapy, and along with that, we have to up-titrate or we have to modify the pharmacotherapy. Definitely, that can lead to sense of well-being, as in our case, sarcopenia is improved, and if we follow this lifestyle modifications for long, the bone mass will improve. And it has been found that lifestyle change might increase mean serum testosterone level by 10 to 30%. In our case, the person, he was very unfortunate. His wife was not sharing the room with him because he used to snore very loudly. So I advised him for sonography, and he was taking CPAP regularly. And following effective and regular use of CPAP, definitely his energy was on the improving side, and he told me that the erectile function also was improving. Definitely, I advised him for SGLT2 inhibitor, and with that he gained some weight. I mean, he lost some weight. Blood pressure came under control. Blood sugar definitely showed some improvement. But one important issue with SGLT2 inhibitor in this background, SGLT2 inhibitor can lead to some degree of erythrocytosis. So a person who is definitely maybe a candidate for testosterone therapy, SGLT2 inhibitor should be used with caution. Definitely, I had advised him for PD5 inhibitor, and after using all these drugs, after following all these measures, he came back to me after 3 months with partial improvement. He was happy, but he wants more. So we have to take care of the expectation of the person. So I definitely discussed with the scope of testosterone therapy, the potential benefit as well as potential risk. And as we know, the potential benefit means with testosterone, patient can improve the sense of well-being. Definitely, the interest will improve. Definitely, the harmonies will improve. With that, we can expect some improvement in the depressive behavior, irritability, and mood. But cognition is not expected to improve much. Definitely, I have convinced him that you are going to improve in terms of some physical strength. I had also warned him about the potential risk following taking testosterone, erythrocytosis, which is the commonest side effect and which is the commonest cause of discontinuation of testosterone. So after discussion all these issues and after exclusion of all important contraindications like metastatic prostatic cancer or breast cancer, I put him on testosterone. As he is suffering long-term hypogonadism, as per my assumption, so I told him, I discussed him all the options of testosterone therapy, starting from parenteral, there is an intramuscular injection, to intranasal therapy, also the scope of intradermal therapy. So after discussing all the scope, all the options left for us for testosterone therapy, he selected 4 testosterone injection as he thought that it will be economically viable for him, and regarding compliance, he was confident that every 2 to 3 injections he can continue. So I told him to take injection 150 milligram every 3 weeks initially, and I assured him that he will come back after 3 to 4 months, and at the time of monitoring, he should come back with a testosterone level of the median testosterone level. Median means I have advised him to take testosterone every 3 weeks, so I told him to get one testosterone level on D10, that is the 10th day. And when he came back after 3 months, I saw the testosterone level is on the higher side. He is feeling better, but definitely the testosterone level is still below 350 nanogram per dl. I also discussed about whether he is having more snoring. He told me that no, snoring is not deteriorating. So I increased the dose. So this is the purpose for monitoring of testosterone replacement therapy, to check whether he is responding well, to check whether there is any adverse effect, and to see whether the person is compliant or not. So, ladies and gentlemen, to conclude, regarding diagnosis and management of hypogonadism in the background of type 2 diabetes, we have to be very careful about the properly timed sampling. In most of the cases, the hypogonadism is not the primary or secondary, it is mixed in nature. Scope of lifestyle modification should be utilized primarily. Analysis of risk and benefit with use of testosterone should be discussed and explained with the person concerned, and proper monitoring of testosterone therapy, if required, discontinuation of therapy should be explained beforehand. So, there is a time when the people had to suffer silently, and I think the time has come when we can say no to silent suffering. Thank you. Thank you very much, Dr. Datta, for that insightful presentation. Now I would like to request if there are any questions from the floor.
Very excellent lecture.
Thank you,
You just talked about SGLT2 inhibitor and SGLT2 inhibitor with testosterone therapy. So, in clinical scenario, how much is it significant? Because as Datta, I was talking that so psychosis is the main concern here. Both the SGLT2 inhibitors and testosterone. So it is not a contraindication.
We have no, there is no contraindication. SGLT2 inhibitor therapy is not a contraindication to testosterone therapy, but we have to be careful because SGLT2 inhibitor can give rise to some degree of erythrocytosis. So we have to be careful, but it is not a contraindication. Contraindication to testosterone therapy is very limited.
Good evening, sir. Sir, just speak some highlights regarding oral testosterone tablet. I can get that. Oral testosterone tablet.
Yes, definitely there is also a scope of oral testosterone therapy, but in that case the cost will be higher, and you have one has to take at least two tablets, and it has to be taken twice a day. So I think it is not viable in that direction. But if we take intramuscular injection, so that is commonly used in our country because of the economic consideration, it is cheaper.
the outcome is same. Injection and oral outcome is same.
If we think of injection, definitely it will be long lasting. So if you have to stop, then you have to stop. If you have to stop suddenly, think the patient has developed psychosis or patient has been diagnosed to have CF prostate. Then if you think of oral drug or anything transdermal or anything intranasal, you can stop it immediately. But in case of injection, you don't have that scope. If you think of outcome, if you think of the efficacy, there you can help. In case of injection, rather, the fluctuation of the testosterone level and the fluctuation of mood is more. But in case of the drugs which are surplusing, their fluctuation in the mood is not that much severe. So in that way, they are more effective to give you a steady state level of concentration.
Thank you, sir.